Hi, everybody, and hi, Michael. It's a real pleasure to introduce Michael Bode from the Queensland University of Technology. It is 6 a.m. tomorrow, so he's I appreciate getting up really early. We do that a lot here in the West Coast as well, so we know what it's like. Really appreciate that he's taking the time to be with us. He's an applied mathematician in the School of Mathematical Sciences at QT, and his research sits at the intersection of mathematics and sustainability science, with a particular focus on decision-making processes in systems where social, political, and economic constraints fundamentally shape what can and cannot be achieved. Michael works closely with governments and international organizations on problems ranging from conservation planning to global target setting, and his work aims to translate quantitative analysis into practical, policy-relevant insights. And I have become aware of Michael's work as part of the Lancet Commission. We both served on the one for anemia. And when I read the draft, I was really excited to read his thinking because it's so different. It was a really well-written draft, and so I enjoyed reading it. So I'm happy to share this, his way of thinking about SDGs with all of you. Please go ahead. I'm going to mute us, and then we'll take questions at the end.
All right, thank you. I hope you can hear me well enough online and over there. And look, I don't mind getting up early. I'd normally be awake at this time, and I'm just thankful this doesn't. In Australia, we often have meetings that go to the United States and Europe, and that's a brutal time to wake up. So this is actually great. The work that I guess I'm going to talk about here starts with that Lancet Commission, and in particular, one of the sections of it that was about global nutrition targets, and in particular the anemia target. And then sort of, I guess, goes a bit broader to health development targets in general. Anyway, so thanks a lot for the invitation. I'll try to make this comprehensible, even though a lot of it's, I think, quite broad and multidisciplinary. I have a lot of trouble with it myself, actually, trying to get my head around all of it. And it's all very much the work of a lot of people beyond me. And these people you see on the screen here were involved in the section on target setting in that commission, which had, a lot of authors, but there's inputs from a wide variety of people that I'll get to back at the end. So I really want to focus a bit broadly at first, and then I want to narrow down to anemia targets and then broaden out again. And I want to start by thinking about targets themselves, like what are they? Why are they? And I think at the moment, the most sort of famous target, international development target that we hear about all the time is the 1.5 target under the Paris Agreement that was signed by the world's nations in 2015. And it's to limit average annual temperatures on the planet to 1.5 degrees above the sort of pre-industrial baseline. And as a mathematician, and maybe as someone with maybe some quite narrow thinking, when I first saw this, I was like, 1.5, what a curious number. Particularly the decimal place, like 1 makes a little bit of sense. I love units, and 1 is always identity. 2 would be interesting. 1.5, why? Why 1.5? How do we set these targets? How do we come to these conclusions? And the more you think about it, the more you see them everywhere. And I work in biodiversity conservation a bit, and we have targets there as well. In fact, we actually, to be a bit arrogant, we've had targets for a very long time. And one of our key targets is around protected areas, like the sort of world's national parks. And we're currently trying to pursue this 30 by 30 target, which is that 30% of the world's terrestrial ecosystems and 30% of the world's marine ecosystems will be inside well-managed protected areas. So, you can't extract things from those areas by 2030. 30 by 30. It's a catchy title. Makes you wonder whether catchiness was one of the motivations for it, which is a curious objective for an international development goal. Many of you will have come across the HIV 19-90-90 targets, which I probably shouldn't have started this sentence because I think it's 90% of people who are HIV positive know their status. 90% of those people are receiving antiretrovirals, and I believe 90% of the people receiving antiretrovirals are experiencing viral suppression. So it's a bit of a disaggregated target, but you can see again, there's dimensions of it, like the repeated 90, like the round numbers that say something about how these things are chosen. And they're everywhere, right? Like if you think about this, there's targets for tuberculosis. The New START Treaty had a target of reducing strategic nuclear warheads by 1/3. We set ourselves these targets all the time. And again, as a mathematician, I wonder, like, how do we set the precise number that these targets highlight? In the space of nutrition, and I think a little bit about the global nutrition targets, we set ourselves 6 different international development targets, more or less saying every country in the world ought to pursue these 6 goals and ought to deliver a reduction in them by a certain amount. And so you can see here, I believe the first one is that stunting, and you can correct me if I'm wrong, is that stunting should reduce by 40% in every country. And this is from a baseline set in the 1990s. I'll get to that by 2030. I think it was 2025 originally, but it was changed to align with the SDGs, the Sustainable Development Goals. The second one that I'll talk about a lot today, which is that anemia in women of reproductive age should decrease by 50% from its baseline. There's also targets for low birth weight, for childhood obesity, for breastfeeding of women, of children, and wasting. So we set ourselves these targets, and you can see the numbers here are interesting because they are both round, they are very different. They range from a no increase in childhood obesity to a 50% decrease and a 50% increase in different targets. How do we set these things? And that's what I want to talk about today. And I want to talk about how we set them in the past and how we might want to set them in the future. But let's get to the one that we're talking about today. And so I'm narrowing down from every single goal we set ourselves in the international development community to a single goal here, which is SDG target 2.2.3 and Global Nutrition Target 2. And that's the one I pointed out earlier. It's in every country of the world, take the prevalence of anemia in women of reproductive age, and by 2030, reduce it by 50%. So let's think about that. Let's think about it, I guess, how it's calculated. Let's think about it grammatically. Let's think about it in all different dimensions. And the first thing I want to do for those of you who aren't thinking about goals and targets all the time is sort of define my terms here. Zero hunger is the SDG goal. You might think of this as equivalent to the entirety of the global nutrition targets. And it's like a high-level vision statement that tries to define one of the many dimensions of human development that we would like to improve. In this case, nutrition, hunger, famine. One of the earliest, one of the 4 horsemen, like one of the problems that humanity's always faced and would like to overcome. So this is a goal, but it's not a target. It's not a specific thing. I mean, hunger is not specific enough. Nutrition is not really a target. 0 technically actually is a number, but we're going to pause. It's more a rhetorical number in this context. This is our goal. When you hear me talk about goals, that's what I mean. Now, inside that goal are a very large number of indicators. And indicators are quantitative measures that we use to try to track, our progress against one sort of aspect of this goal. One aspect of nutrition, one aspect of famine. And it's tricky because you can think of these different indicators as different nuances to the word hunger, to the idea of nutrition. But you can also think of them as multiple attempts to measure the same thing because it's always imperfectly measured. Right? It's very hard to measure these things at a global scale in every country. And so sometimes we try to measure them in multiple ways to get a better idea of them. But sometimes we're trying to measure different types of this dimension of development. That's our indicator. Again, we're not yet at the target. Our target is this one here. It is to halve by 2030 that indicator. And so we have this structure, right? At the very top end, at the very vision end, we have the goal. And at the very low end, the very tactical end, we have a specific target for an indicator that represents that goal. That's what I'll be talking about. So let's go back to these SDGs. This is my target for anemia, and it's something that the international community sets itself. And it's reasonable to say, this is just a rhetorical object, right? This is just something that we say to focus our attention and to, enthuse the troops, right? You wouldn't imagine that like a pep rally chant has any understandable meaning or binding purpose. But these are not purely vision statements. These aren't purely rhetorical objects, right? And you can see that in their detail, right? Like if all we cared about was encouraging people to deal with nutrition, we might just stop at zero hunger. We get down into the details for a very good reason, and the consequences of that are not zero. And so it might not be obvious all the time, but like development goals aren't just these symbolic objects. So there are indicators aligned with the SDGs that are embedded in all sorts of sort of real world mechanisms, multilateral lending frameworks, disbursement conditions for loans, sovereign bond structures, eligibility for climate finance, the way that the insurance companies model risk and treat countries when they try to insure or reinsure them. So basically things like borrowing costs, access to concessional finance, exposure to things like regulatory or market opportunities, but also like the way that we think about risk in these contexts. These are all connected to the SDGs, to their indicators, and to progress against the targets. And so they really shape real world economic consequences and how we frame them, how we, which ones we choose, the targets we set for ourselves. These percolate through in maybe surprising ways, even to the founders of these goals, to changes to the lives of people on the ground. And to give one example, Peru has a nutrition program that at one point in time tried to give micronutrient supplements to every child in the country. And it did that to try to, among other things, tackle its anemia, but it had no response. And that was looked upon explicitly in international lending circles by things like the World Development Bank as a problem, right? It could be a condition on a loan. If you're not making sufficient progress against these indicators, you don't get tranches of the loan payments. You might even lose the opportunities to get those loans. And yeah, I think those ideas are not necessarily in the minds of the people who set SDG target 2.2.3. And nevertheless, they have those real world consequences, which I think means that it's incumbent on us to think about them more carefully. So back to these indicators. I've got here the United Nations paper on the indicators. It's very small. That's a list of a subset list of the indicators that we set ourselves. I believe there are 178 or 193. There are almost 200 different indicators, among which sitting there is 2.2.3 on anemia. And so there's hundreds of these things. And it begs the question, how were they chosen? What's their purpose? And so if we were to choose them again, how do we set them rationally? And the third part of my talk will be basically like, this is a rational approach to target setting, but it has to fit within a broader process. The SDGs are effectively an international treaty, an agreement, a mechanism, an instrument. And if we have a better way to set these targets, it doesn't just have to be better. It has to understand how that broad structure works and operate within it. So those are the three things I want to talk about today. How are these targets first set? How might we set them in the future in a better way? And once we work out a better way of setting them, how can we incorporate that into the political process that they sit inside? So let me go through those things as quickly as I can. Question one, how are these targets set? Now, you can read the World Health Organization's working paper from 2012 if you want that question answered for anemia. But basically what they did, and what was being done a lot at that time around target setting, was what you might think of as a best-in-class framework. They looked across the countries of the world, they looked across the last 5 or so decades, and they said, which countries have achieved rapid progress against anemia for relatively sustained periods of time, 5 to 10 years? They highlighted China, Nepal, Sri Lanka, Guatemala, Vietnam, and they said, look, at certain points in time, these countries were able to deliver a more or less 4% year-on-year reduction in anemia. We therefore think that that's a reasonable goal to set for every country in the world for the SDG period, which runs basically over about 15 or 20 years. And so if they looked at China as one of these exemplar countries, they looked at a graph of China from 1990 to 2020, for example. And they said, okay, we're going to set a baseline against which the target will be evaluated between 1993 and 2005. That's the green area. And we're going to say, okay, that's the 0 point, right? We want you to reduce 50% under that. So whatever was happening in around the year 2000, we want you to halve anemia from that point. And you can see here that China, and this is some data from the Global Burden of Disease Project that was published in the Lancet Haematology. And these authors in this data are behind a lot of what you'll see in anemia coming forward. But you can see here that China was able to achieve quite marked reductions in anemia for a sustained period of time throughout the 1990s and 2000s. But nevertheless, if you were to watch their progress to date and extrapolate it linearly into the next, say, 10 years from when we started doing this, or when the last GBD was doing their estimates, you can see that China would fail to meet its SDG target, which is that horizontal blue line. And if you look at all the countries of the world and you treat them the same way, you sort of standardize them for that 1993 to 2005 period, you can see that by 2023, which was the end of the data set we were looking at the time, most countries had achieved a moderate reduction in anemia prevalence. A few countries had experienced an increase. Some countries had actually achieved quite a large dramatic decrease, but no country was looking at achieving its SDG targets by 2030. There would be an almost universal failure of the world's countries on target 2.2.3 for anemia, or if you like, the GNT's target 2. And the World Health Organization talked about this in their discussion paper from last year, where they said, look, here we are in 2025 in the far left hand of this graph. If we keep going the way things are going, we'll probably see globally a bit of an increase in the prevalence of anemia. If every single country from now on, like starting today, starts to perform as well as the best 20% of countries, we will see a bit of a decrease. But we're going nowhere near our SDG target down here. Basically, we need to get off this blue line here and onto this gray line. And they don't say this, but that seems unlikely. And this is not a problem specific to anemia. It's not a problem specific to nutrition. It's a problem you see across the Sustainable Development Goals. This is from the SDG dashboard. Instead of the usual, hypersaturated color variation of the SDGs, these ones here are all color-coded by our performance in a global sort of community of nations context against them. And you can see that all of them are facing major or significant challenges. There's a very good chance that by 2030, we won't just have failed the GNT and the SDG for anemia, we will have failed almost every one of our targets in every one of our countries. And I'll get back to why that's a problem and what we should do about it, but this is not a purely anemia-focused problem. However, it does reflect on the methods that we use to choose these targets. And so my question is, going forward now, beyond the 2030 Sustainable Development Goals, which are what feels like a matter of hours in the future, given the way time's passing. But following this, we're hoping that there'll be new targets set, particularly for anemia and nutrition, right? What should they be? We clearly, I think, should not set them at 50% again, but should it be a 25% reduction? Would be moderate in our aims? Should we be slightly more realistic and a little less ambitious and set it at 40%? What do we do? Like for the next 15-year period, for the, I don't know what they're going to call the post-SDG goals, the NDG goals, the next development goals, what should we set our target for anemia to be? And the purpose of our section of the commission was to try to think through that specifically for anemia, to say like, okay, there will be WHO meetings, there will be INS meetings where we'll talk about nutrition, we'll talk about anemia. Going into that, what should we think about the target for anemia being and the process for target setting as being? And so I want to briefly talk about that. What should the next set of targets be specifically for anemia? And so our conclusion was, after some thinking that you can read about in the commission, that a good target should be a combination of ambitious and achievable. It should be ambitious because, of course, that's basically the overarching purpose of international development goals. We want to encourage action and investment. We want to prioritize resources and research. We want to measure and test accountability for people. We want to understand what works and what doesn't. We want to have countries we can look to and learn from, and countries that we can look to and learn from for the other reasons. But it has to be achievable to some extent. Universal failure is demoralizing and disempowering. And targets that seem initially unachievable based on their sheer magnitude and our performance against them in the past don't carry any sort of power or encouragement. And if we have this outcome of universal failure again, we'll lack any accountability or differentiation. Countries that don't try hard can hide amongst the countries that try harder and still fail. Countries that try hard receive no credit, receive no positive feedback, and in the context, as I said earlier, of the real world implications of these, don't get the benefits that all the other mechanisms would like to give to the countries that are making the progress that we want. And so basically this overarching target for anemia that we should halve prevalence in every country by 2030 in women of reproductive age is a poorly constructed target because it fundamentally, it logically fails the aims of being both ambitious and achievable, right? It can't be ambitious and achievable primarily because it ignores the different national contexts of all the countries who've signed up for it, right? We have a situation where a target like 50% reduction is going to be achievable for some countries because of their capacity, because of the challenges they face in their health system and in the population and demographically. And it's not ambitious for them because they can easily achieve it, right? It's achievable for those countries, but not ambitious. And we have the other countries which, for capacity reasons, for demographic reasons, cannot deliver, no matter what they do in the sort of toolbox of options, a 50% reduction. For them, 50% is very ambitious, but it's not achievable. They're almost predestined to fail. And if we set any individual single goal for every country in the world, it'll be a combination of unachievable for some countries and unambitious for others. And so the solution has to be national targets. It has to be a nuanced, individual, country-based assessment. And we propose that be based on health economic modeling through a pathway of proven interventions. We have to know what's going to work, and we have to detail how that's going to be achieved. And it has to be achievable with a reasonable level of investment. Those, I guess, are the 4 dimensions of the solution we're proposing for the anemia target and some of the nutrition targets in general. National targets based on pathways that we can link to reduction based on a reasonable level of investment. And so let's see what that looks like in a detailed sense for anemia. To answer this question for anemia, we have to work out, 1, how much anemia is there in each country? And I'm not going to talk about that because it's basically the work of the Global Burden of Disease Project. 2, what are the interventions that we have available for us that we can point to and say, that is what I would do? Not just what reduction will you deliver, but that's how I would deliver that reduction. How much do these interventions cost? And how much can each country afford to spend on those interventions at that cost to reduce the anemia they have? Together, these 4 questions can help us answer that target question for each country. And we applied in the commission work this to every country of the world based on, global data sets. So step 1, what interventions work for anemia? We went to the WHO's e-library of evidence for nutrition actions, and we identified and selected interventions that had solid evidence behind them. Basically, that had randomized control trials that demonstrated that this action could reduce anemia, and ideally with a few covariates that could, understand how that might, work at each individual country level. And those were oral iron and folic acid supplementation for pregnant women, presumptive treatment of malaria for pregnant women in countries where there's endemic malaria. For non-pregnant women, oral iron and folic acid supplementation at a population level, and at a very high, general population level, staple food fortification. These are the basic tools we had in our kit. And basically what we're saying is, when we say a country can achieve a certain reduction, we are saying it's one of these methods that we know can deliver a reduction that we recommend be used at a certain level. For each of them, we estimated their costs, their effectiveness, the current and potential levels of coverage each country had, and a bunch of covariates that mattered. To give a very simple example, presumptive treatment of malaria in a country like Australia would be a very ineffective intervention, not because it doesn't treat malaria that's not because it doesn't treat anemia in malarial women, but because Australia lacks a high population of malarial women. Natalie and Tori did the health economic modeling that allowed us to understand how much each of these interventions cost in each of the countries. And so we aligned our approach to costing interventions with the WHO choice methodology and the One Health costing tool. That's the basics of approach we used, along with some other similar multi-country anemia costing studies, such as the World Bank's investment framework for nutrition, which I believe I showed you in the previous slide. We adopted a specific healthcare sector perspective rather than, say, an individual one. So we included only the costs that were incurred within the formal healthcare sector. That was obviously his choice. The costs we calculated were the per person costs of receiving an intervention for a year. And this was made up of four components you see on the slide here, which is basically the cost of the commodity. So the cost of an iron tablet, the supply chain cost of getting it to the person's door/mouth, the cost of a healthcare service delivery, maybe a healthcare worker to explain and provide counseling alongside the supplements, and the administrative program costs like community sensitization or training. And these costs were each aligned to the WHO choice methodology. And they allowed us for each of our four interventions to say per person, per year, what does it cost to deliver this intervention to tackle anemia? Now, the other part of it was the cost effectiveness thresholds, which were basically used to represent the upper limit at which the cost of an intervention are considered an efficient use of resources. So when we say in our sort of overarching theory of targets, we want the targets to be achievable, really. Part of what we mean there is a country could reasonably be expected to spend this much money to target anemia with this intervention. And the question then that comes is, well, what is a reasonable amount of money to spend on reducing anemia? And that basically comes down to, in health economic thinking, how much does it cost to reduce the burden of disease in that country by one disability adjusted life year? And there's a variety of approaches to do this, and they're super important to what we set the targets at. They're basically like, what could you reasonably expect a government, a nation to spend on reducing anemia to the extent that a DALY is reduced? And at one end of the spectrum, we have the classic approach, which I think was put forward by Jeffrey Sachs, which is 1 GDP per capita, right? If it costs you more than 1 GDP per capita to reduce DALYs by 1, don't do it. If it costs you less than 1 GDP per capita to reduce a DALY by 1 with an intervention, do it. And that was our first approach. We tried a variety of others because these are very uncertain and complicated ideas. And so we had others that were a bit lower, some that were a bit higher, just to see the effect on our conclusions about the targets. And so what does that look like? Here's a simple example. We have a hypothetical country with an anemia prevalence of 40%. So let's take somewhere, say in sub-Saharan Africa. There's one intervention available, only one, right? And it has an effect size of 0.8, which means that if you give it to 10 people, by the end of it, 8 still have anemia and 2 do no longer have that. The coverage is currently 0%, so nobody's getting this intervention yet. It's newly developed. And we can afford to, with our cost effectiveness threshold, turn the coverage up from 0%, where it currently is, to 100%. So this is an ambitious situation. Now, the model would predict in that context that anemia in that population would reduce from 40%, where it started, to 32%. And that would be a reduction target of 20%. So that's the sort of thinking that we went through. For a very simple example, obviously there are multiple interventions. Obviously there are existing coverage levels. Obviously we can't afford to increase in coverage to 100% every time. It's also not possible in some contexts. And so what we have is a target that is constrained by sort of 4 factors. One, it's constrained by the size of the problem. How many people have this problem we're trying to deal with? In Australia, for example, anemia is relatively low. In places like Malawi, it's relatively high. The targets are constrained by the interventions that we have, right? If we don't have a lever to pull, then we can't reduce the burden of whatever we're talking about. The targets are constrained by the existing actions on those levers. If people are already pulling hard on them, then we can't pull much harder, maybe not for a reasonable price. And finally, targets are constrained by the cost of interventions and our ability to afford that cost. So all these things go into what we would defensively set a reduction target as. And we went through every country of the world, obviously not by hand because that's what computers are for. And we set those, we estimated those values for every country and we set a target. And that was the end of the analysis. And you can see the results here. These are the world's countries color-coded by the target we set for them, where very purple countries have a very high target of reduction, up to 40%. And the very light countries have a very low target of reduction. And you can see some patterns in those countries, right? You can see that, generally speaking, the sort of global north has lower targets and the global south has slightly higher targets. East Asia has some of the highest targets. Africa has a high variety of targets, some very high, some very low. And so you get this nuanced picture of what a target should be. It's not as simple as it currently is. 50% reduction, it's complicated. And I want to go to Malawi here and show you that behind all this thinking is a pathway for achieving it. Detail about what we're assuming here and the interventions that we think would be successful in that country and to what extent they can be increased given what we think the country can afford. Also, how much they would cost to increase. And I'm doing this because we're going to get back to the pathways issue later. Not much later. So you can see we've got anemia reduction in Malawi. There's a national target. There's our assumptions about costs and prevalence. And then there's the cost of the different interventions. And at the bottom, the cost effectiveness thresholds. And so what this is showing is not just that Malawi's target should be, and I can highlight it here, a reduction in prevalence by 4%, according to our best estimates, which is why Malawi in our previous slide had such a light color, but an explanation why we think it should be 4%. And if you look at this across all the countries of the world as a caterpillar plot, you can see our primary sort of conclusions here, which is that there are a lot of targets. They range from as low as 1 or 2% to as high as 30%. Each one of them is a target, yes, but it's also an uncertainty bound because all of the inputs that we've listed are uncertain, particularly when analyzed as we did at a global scale. We don't know precisely what the prevalence of anemia in these countries are, but we do have some understanding of how uncertain we are. We don't know the cost of these interventions precisely, but we do know how uncertain we are. And so we take all those uncertainties together and using a process called Monte Carlo sampling, we propagate them through to our conclusions. We don't come up with a single target, we come up with a range. And that's good, right? Because we are uncertain and it ought to be in our conclusions. But what you can see is one, there are national targets, and two, that the overarching global target is about 17%. And this is, I guess, part of our sort of sale point for this approach. A single global target still remains. A single simple sentence you can tell people about what the world's governments are aiming at still remains, but it can be disaggregated down to a country level. Now that 17%, let's focus on that for a second. When we look at our different assumptions, and these are different cost effectiveness thresholds here on the x-axis, and there are also different assumptions about what the initial coverage is and how much money we have, you can see that the targets change. This red dot here is for all countries. The blues are for lower and middle income countries. You can see that it's, like I said, about 17% is our best guess. If we had more money, we might set it higher, 25%. If we had less money, it might be down as low as 10%. We're uncertain about it. It might be, even though I'm saying 17, as high as 40 or as low as 10. But in none of these scenarios, in none of the uncertainty analyses, no matter how we tortured this model, could we come up with a 50% target for anemia. And so our conclusion is, yes, we're uncertain. Yes, there are assumptions we made. Yes, doing this sort of stuff at a global scale is uncertain, but 50% is absolutely unachievable. We can't think of a single plausible mechanism through which any country could achieve a halving of their anemia using the tools they have available to them. Anyways, that's our conclusion about anemia specifically. And I want to spend the next 5 minutes briefly talking about the problems with this approach. And primarily, I guess, how we can surmount the sort of complexity and technocratic focus of this approach to the real world political context of trying to set development goals. So the problem with development goals is that they actually have to be implemented in some of the most ugly and complicated situations you can imagine, which is United Nations General Assembly discussions. 190 countries who all have to come to an agreement about what the target should be. That basically, and you can see my conclusions here, makes detail and nuance a tricky thing to try to communicate because everybody in the room has to understand it, and they have to understand it in a very time-limited scope, right? These are a few days of meetings with lots of different subcommittees. We have to have basically a set of targets that are equitable or perceived to be equitable. And we have this problem with enforceability. And so we need a mechanism that I think takes some of the really good parts about the Sustainable Development Goals, their vision, their simplicity, their sort of their focus, and nevertheless is setting these targets at a scale and a level that is credible and fits within the architecture of international governments, but delivers outcomes. And so I want to finish, and I'm going to finish with two things here. Briefly, a discussion of how international climate agreements have dealt with this. And so what we see back in the days of the Kyoto Protocol in 1997 was a very top-down, target-based carrot and stick approach to achieving targets. Now, Kyoto Protocol said there's an overarching vision, just like the SDGs do, and that is that we reduce global emissions by 5% on 1990 levels by whenever the end of the thing was. I think it was like in the 2010. And it basically said there are binding targets for every country. So Australia, for example, had a target of an 8% increase. Thank you. Thank you to negotiations, because we're a fossil fuel intensive country. But basically, we had a target of 8% plus 8%. The European Union is a good example. They had a target reduction of 8% on 1990 levels. So really hard targets. And for a variety of reasons, they didn't work out that well. Partly because they weren't universal, partly because a lot of countries failed. And so the solution going forward was implemented under Paris, and it was a very bottom-up approach. It said, we're not going to set these quantitative targets for you. What we want you to do is go away and come back with nationally determined contributions, what you think you can, at your highest possible ambition, deliver. And we will look at those, and we will have you come back repeatedly during the Paris Agreement period and report on it. And we will transparently communicate that to everybody. And what it understood was, in reality, the mechanisms that encourage achievement in these contexts are actually domestic. And the role of the target architecture should be to provide feedback on how a country's performed against its own metrics and how a country's performed against other countries. And it's through that transparency, siphoning through, I guess, domestic pressure that we have change. And so that's what we're proposing would be true for an SDG future too. That basically the SDGs take on what's been happening across a whole bunch of these sorts of conventions to try to focus on it, to try to focus on achievement. I'm conscious of time, so I'm going to finish off with just a sort of conclusion about this, which is one of the overarching reasons to think about this, I guess, target setting again and be really careful about it is there's been a lot of these sorts of targets throughout history. There's 6 or more decades of target setting and evaluation. And the Sustainable Development Goals are like the apotheosis of that. They're a fantastic, compelling set of targets that capture a wide range of development goals and have, partly because of their beautiful hypersaturated color schemes and sort of Swiss graphics, they have permeated the consciousness of not just the United Nations, but domestic governments, right? So the Australian government reports on its performance against Sustainable Development Goals voluntarily. So just like it kicks them up and says, oh, by the way, you know, this is how this legislation we just passed aligns with Sustainable Development Goals. If I walk down my corridor, I see occasionally SDG targets put on the screen. I went to my local bank last month for the first time in a very long time, and they were reporting on, in a corporate sense, Sustainable Development Goals. These things have entered every facet of, I think, you know, civil society and government, and that's a great thing to focus attention on development. Development goals, the vision they offer, is a valuable thing. We're going to come to the end of the Sustainable Development Goals, and I bring you back to this dashboard with almost universal failure. And against that backdrop, we're going to say, let's set these again. Let's have some new development goals. And there's a real risk that this performance here, this universal failure, will be like a disempowering change. And I'm just going to finish now by saying that we need to come to the next set of development goals and the pivot point between them with an explanation of why we failed and a solution going forward. And I would say that the explanation is because the target setting was poor, not necessarily because the country's performance was poor. I think that's an empowering and productive conclusion to draw, as opposed to, yet again, we've fallen short of our own goals. And these are the papers that are behind some of this thinking. Email me if you would like them.
Thank you so much, Michael. Yeah, we have some questions in the room, and please raise your hands also online if you have questions.
Yeah, thank you so much for the presentation, and it was really insightful to hear about, you know, how these goals were set and all the advancements that have been made. I had 2 questions, and I was just kind of curious to hear your thoughts. So the first thing I was thinking about is what you showed earlier with the example from China really kind of to me illustrated the choice of the reference period is really important. And also in the sense that, you know, like you could also have mean reversion where countries that happen to have very high anemia prevalence in the 90s or early 2000s because of, say, there was like a famine or something else that was going on, and it was naturally going to come down anyways. So I guess what I was curious to know was when you were developing these new goals, did you think about creating like unique reference periods for each country, and how did you kind of think about like creating the reference periods? That seems like it's really critical. And then my second question was, when thinking about the effect of the interventions, it seems like it would also be important to kind of distinguish between like RCT settings and those kind of like effects versus the effects from like public health rollout. So how did you guys kind of distinguish between those like RCT effects and maybe the more like intent to treat effects of like actual public health program rollouts?
Thank you for those questions. I can't see you, but that's an amazing set of questions. And my answer is yes, and whoops, but in the other option, in the other direction. The point about the reference period is really important. And I guess when I wrote down the target verbally for you guys, I missed the reference period because really, if you said it in toto, it would be every country should achieve a 50% reduction in anemia prevalence based on the 1993 to 2005 baseline by 2030. That's a really important part. And when it comes to other dimensions of target setting, particularly around climate and emissions, that's a huge deal, like the baseline period. And countries, particularly in things like emissions or deforestation, often game the baseline period. They might, over-report or even like over-emit during a baseline period so that their goals for the later period are a bit lower. That's a really important one. We didn't think about it enough, actually. I guess, yeah, we just basically did the implicit assumption that there would be another baseline period, and the question is not so much what that baseline period should be and how that would affect your target setting, but what's a rational way also to think about that baseline period. And I guess you could move away from the baseline period entirely and think about things like, given your demographic and socioeconomic profile as a country, what's like your sort of, what would we expect anemia to be in your country already? In a modeling sense is the one I would think of immediately. I'm gonna have to think about that a lot more. That was a great point. On your second issue, which was, we have this data from RCTs, and we see that interventions have quite a marked effect on anemia. What would that look like in the real world? And that came to mind most clearly in iron supplementation, which using micronutrient patterns or even just straight iron, which was showing like a relative rates of 0.3 in RCTs, but is often rolled out at national levels and achieves almost nothing. The Peruvian case I was talking about, I think before, was a famous one where they did quite large-scale childhood treatment of anemia using micronutrient powders and experienced a slight increase in anemia, which obviously there are other factors that might affect that. But so the way we incorporated that was by a technique known as voltage dropping, where the theory is that in general there is this voltage drop between what you can achieve in an RCT context when there's obviously like, it's a very small scale approach. It's often targeted to places where interventions and action are easy, and there's follow up and there's like, I guess, a formality to it. So normally there's an assumption that on average you get a drop of about 30% from the RCT level when you do these things at scale. Of course, there's a lot of uncertainty in that, and so the predictions you saw there incorporated the average voltage drop and also the variation that people see across interventions in that voltage drop. And we specifically use the voltage drop for nutrition interventions, which I say confidently, but it turns out that a lot of nutrition interventions are more behavioral-based nutrition interventions in developed countries around, say, childhood obesity, for example. And to what extent the voltage drop for that particular intervention applies to more nutrition-based interventions in lower and middle-income countries is an open question / is probably not that perfectly applicable. But that we did incorporate it through the voltage drop is my answer. But thank you for that first point about the baseline. I'm going to have to think about that much more carefully.
Steve, go ahead.
Thanks. Michael, excellent presentation, excellent work. Thanks for getting out of bed early for us. Um, I really like the approach, but I'm wondering whether you've made much progress in all the different kind of learning societies that chime in on this. Any progress in getting them to adopt this? So you worked intensively with the anemia folks, and I'll bet every one of them would vote yes on it. But there's a whole lot of other impact indicators that are kind of decided upon by other learned societies or groups of them. And we'd have to basically convince all these folks that your approach is the way to go too. And so is there a kind of a higher level push to get these folks involved and become champions of what you're suggesting?
Yeah, thank you. And any advice you've got on that dimension, I'd love to hear. Briefly, I would disagree that the anemia folks are on board with this. So we talk a lot to the WHO nutrition people, and they're feeling. I think they're coming. I'm not saying they're coming around to it. I think there's been like an organic meeting in the middle between us and them. And I will say that an earlier version of this talk would have been much more, because I'm a bit simplistic in my thinking, critical and quantitative. But there has been some progress. We think that the obvious place to expand it to post-anemia is nutrition more broadly, and then to health in the health dimensions of the Sustainable Development Goals. Partly because we think that the DALI approach and the cost-effectiveness threshold ideas apply to certain types of indicators much better than others. So I don't quite know how to approach target setting for indicators like peace or even gender equity, because I'm not quite sure how to evaluate the performance dimension. But if you talk about any of the dimensions of nutritional health, you can think about expressing them as DALIs, and you can think about evaluating what would be a reasonable intervention through cost effectiveness thresholds. Anyway, so long story short, we're currently writing another commission, which is amazing given how painful the first one was to write, on extending these sorts of analytic methods across the sort of across the quantifiable health dimensions of the Sustainable Development Goals. And I guess I'm interested to see what the response will be from the broader community. Certainly because the response from the anemia and nutrition community was very productive and interesting. But yeah, I think I don't know quite even vaguely how to apply it to things like conservation, which is something I work in a lot, simply because I think the framework that we've talked about is so focused on DALIs and is so comparable as a consequence. But yeah.
Any more questions? Raina?
Yeah, thanks so much for your talk. Really appreciate kind of the critical evaluation of these targets and then also the thinking about feasibility. And I was wondering if you could talk more about like discussions that you've had or maybe reactions about implications of kind of having lower thresholds or like I don't know if I should, like a lower bar for some countries in terms of their use for advocacy. And then when you think about affordability, thinking about, in some cases, it's advocacy for external funds for interventions. And if you are getting reactions along those lines, I mean, I think you could also argue that maybe that strategy hasn't been so effective as I see with the progress towards these. But I'm just wondering, yeah, what the discussions have been along those lines.
Yeah, that's a great question. I think briefly, the most common response is that there would be like a deflating effect of not just setting goals that were much lower, but setting goals that were clearly lower in comparison to previous rounds of goals. And that would disincentivize investment in nutrition. And then you get like the slightly competitive nature of the SDGs, which is that if anemia were to unilaterally reduce its goals from 50% reduction down to, let's say, 15% to make it round, or 20%, that would make anemia unilaterally look pretty crappy. And it wouldn't affect like the total amount of investment in global development. It would specifically shift investment from anemia to other ones. I think also there's the issue that you really, I think, clearly pointed out there, which is that when you set these goals, you get this, you can encourage investment and focus on your dimension. And sure, at some point in the future, you get spanked because you didn't get anywhere near what you set it as. But in the short term, which is kind of what you care most about, there's a disincentive to set realistic goals, even though they are ambitious, because particularly if you're the only country or the only, development dimension doing it, if your goals are ambitious, they're less encouraging of investment. And the penalties and enforcement that happen in the SDGs, which I think actually in previous rounds of these development goals have been on purpose, not particularly clear or well communicated. Why would you celebrate your failures? There's no real downside to overpromising. So that's been the most common consequences. To which I would answer, let's set the goals much higher. Why 50%? Like, why choose this halfway ground? We should say 100% eradication of anemia in every country of the world by 2045. And obviously that seems spurious, right? And so somehow in between like spurious and realistic, there has to be some sort of, yeah. And how much of a finger on the scales does encouraging money push you? I guess the 50% would be the answer. But that great question, actually. And that was a bad answer, but thank you.
Great. Yeah, thank you.
Yeah, this is so fascinating to think about all the aspects related to SDGs. I really appreciate your talk, that you took time for us. One more time.
Thank you so much for having me. I really appreciate it.
Thank you so much.